Very good. So good evening, everyone. I was just going through where everybody's from. First of all, I'm really grateful that you've decided to come and join us at 8 o'clock on a Wednesday night, and I hope I can make it worth your while. I'm still at work, so I apologise for that, but I shouldn't be interrupted. So I see people from everywhere. In particular, somebody from Malawi. That's great. I'm from South Africa originally, and Namibia. They're drinking cocktails in Mykonos. Yeah, okay, me too. Great. Birmingham, some people come say hi. So I'm a plastic surgeon at the Royal Centre for Defence Medicine in Birmingham, based at the Queen Elizabeth Hospital. And so I've been asked to do this webinar on wound management. That's a very large topic, obviously, and quite a difficult thing to tackle. I mean, there are people doing their PhDs on wound management, so I'll try my very best. I think it's difficult to interact during the presentation, but please do ask questions afterwards. I'll try my best to answer. If I can't, I'll find out and I'll get back to you. Let's go. Just a disclaimer there. So what we're going to look at tonight. So I have a little introduction, then look at wound healing itself, look at how you assess a wound, how you manage a wound, talk a little bit about dressings, and then go into advanced therapies or advanced dressings, and then we'll do a little Q&A at the right at the end. So to understand wounds, you need to understand skin anatomy, because that's going to be your basis, and you don't need to know a lot. Basically, just how we subdivide the skin into different layers. So the most superficial layer will be your epidermis. So you can see on the right hand side. I don't know if you can see if I move my cursor, if you can see that. But right at the top is the epidermis, then the dermis underneath, and the hypodermis or subcutaneous tissue, as we call it. And then if you go deeper, you're moving into fascia, blood vessels, muscle, and then bone. Or if you're over the abdomen or a cavity, then you're into that cavity. So the skin is the thing that's going to get damaged in your wounds. So what function does the skin hold? What does it actually do for us? So it creates a barrier and allows us protection from the environment around us. It also is useful in thermoregulation. So as you know, if we get hot, our capillaries will vasodilate and we will lose more heat by convection. And if it's cold, then we shut down peripherally to keep us nice and warm. Fluid balance. So our skin's waterproof, and it holds all the water on the inside. So when you do lose part of your skin, then you'll suffer the effects of loss of fluid balance if it's a large area. Metabolic, so it's has a function in converting vitamin D to allow for calcium absorption. Sensation, so we can touch and interact and feel the environment around us. Excretion, so again, if you go for a run or do heavy exercise, you're going to sweat. And then lastly, it's a personal interface. So you seeing me here, you're seeing my skin. It's a way we interact and how we fit into society and how we interact with each other. So there's that interface function as well. So what is a wound? A wound is discontinuity in skin. So if you think about it in terms of the anatomy of the skin, but then also the function of the skin, you're going to start thinking about how we approach it and why it's important. Our wounds are difficult because this is a wound, which I'm sure a lot of you guys have seen before. But this is also a wound. So that's a burn wound. And then this is also a wound. So how do we decide how we treat wounds and how do we make sense of them? So there are a number of ways in which we can classify them. and that makes it useful for you to compartmentalize it and understand how to separate them, put them into different boxes. This is a way of doing it. So if you look broadly at wounds as either an acute wound, so something that's happened immediately, or something that is chronic, so ongoing. And then in the acute, it's either going to be from an accident, so unintentional, or it's going to be intentional, surgical. And within that, you're then going to get different types of wounds. So from the traumatic side, you'll get abrasions, or burns, or lacerations, incisions, stab wounds, that sort of thing. But you can also get bites and crush injuries. Surgical wound, so it could be just be a nice healing surgical wound. It could be one that's dehisced or broken down for whatever reason, one that's gotten infected. And then certainly in my world, it could be skin grafts or flaps that we do. And then if you look at the chronic aspect of wounds, there are pressure wounds. Again, they are horrible things to deal with, but we see them in the community and see them certainly in hospital, less so now than we used to. Venous and arterial wounds, so vascular surgeons deal a little bit more with that, and the next line down, diabetic feet. And then you can get sinuses into cavities, or into limbs, into deeper collections or bony infections. And then you can get fungating wounds that we quite often see with certain infections or cancer. If we want to classify wounds, we need to have an understanding of how deep this wound is. So which layers of the skin it's affected. So remember earlier on, we looked at the epidermis, the dermis, the subcutaneous fat, and then the muscle underneath. And it's the same classification as we use for burns. So how deep down you've gone into the skin is a way of communicating about a wound or giving information to somebody else about this wound. So if you look at this slide, on the left, you've got a very superficial injury, and on the right, you've got fourth degree. We don't really talk about fourth degree. We talk more about full thickness, so the top, not the bracketed bits, and that's increasing severity. So if you've gone into just affected the top layer of the dermis, that's like a scratch or an abrasion. That hasn't gone very deep. That'll be superficial thickness. And then you get partial thickness. Now, partial thickness is any wound that has gone through all of the epidermis and then any part of the dermis. And so that can be only the top layer of the dermis, which will be a superficial partial thickness injury, or most of the dermis would be deep partial thickness injury. This is probably more important in terms of burns and burn wounds, because it might slightly change the way that we manage them. And then lastly, full thickness. And so that's when you've gone through the full thickness of the epidermis and the dermis. So the key area is the dermis. Is it involved? If it is involved, is part of it involved, or is all of it involved? And that's how you classify it into your superficial, partial thickness, or full thickness. We can also talk about wounds in terms of their contamination. So a clean wound, which is great. Clean contaminated wounds. So we quite often see these. So these will be injuries that people have at home. So they might be cutting out some vegetables. They've taken a knife out and they chop their finger. That wound is probably got some contamination in it, but it doesn't have any gross contaminants in it. So that would say that's a clean contaminated wound. And then if you look at more chronic wounds, it may be, may have been there forever. It may not be infected, but it'll certainly be colonized. And that just means there are bugs in the wound sitting there and living away, but they have not reached the threshold of actually infecting the tissue around them. So, and then obvious contamination. So that's when you've got wounds that have got gross contaminants in them. So that will either be foreign or infected material, bits of leaves and gravel or dirt in there if they've been in a road traffic accident or come off their push bike. And then lastly, infected wounds. And quite often you have pus that comes out of that. So clean, contaminated, and infected. So just some pictures. So that picture over there looks like somebody's leg, and you can see a number of different elements in that wound. So you can see there's no erythema around it, so it's not infected. But there's some dead skin, which are those black bits of eschar over there on the right-hand side of the screen. You can see there's some yellowy bits in between the red bits of slough or just dead cells that haven't come away yet. And then you can see the red parts of the wound almost looks cobbled, and that's what we call granulation tissue. So when the wound is starting to heal from the depth of the wound, and is trying to heal itself, pushing up. So that wound, because it's been there for a long time, will be colonized. So it's not infected, but there are definitely bugs in there if you're going to take a swab and send it off to the lab. This wound, though, you can see it's got a bit more trouble going on. So you can see a bit more erythema and redness around the edges, and it's starting to break down at the corners. And so you've got to ask yourself why. Why is it breaking down, and part of it healed? And that's probably it starts to get infected. And I would have thought that might be due to some suture material that's in there, but it could be anything. So in terms of classification, it's a method of conveying information about a wound. So if you can, talk about a wound in terms of its depth, in terms of its etiology or how they got it, the depth, the size of the wound, perhaps, and then whether you think it's clean, contaminated, colonized, or infected, that gives somebody a picture now in their head of what this wound is looking like. So moving on to wound healing. So in terms of intention of healing, so we talk about primary, secondary, and tertiary intention. Primary intention is when you've made a cut. So think about surgical incision. You've made a cut and you've put the skin edges back together with stitches. That heals by primary intention. So you oppose those skin edges. Secondary intention is we decide not to close the wound. And that may be for a number of different reasons, but you leave it open to heal by itself. Quite often if they're grossly infected or you have an abscess and you don't want to close over the top to allow it to recollect. And lastly, tertiary intention. So this is where you maybe have a wound that you go and wash out or debride and clean up in theatre, but then leave to see how whether any of it becomes infected or how it fares over the next few days before you then go back to theatre again and close it, or you close it at a later date, usually within a few days rather than weeks down the line. In terms of wound healing, so phases of healing. Hemostasis, first phase, then inflammation, proliferation, and remodeling. So these phases are on a continuum. So they don't all happen, it's not one thing that happens at a specific time. They overlap. So as the one starts, the other and starts to tail off, another one might start, the next process might start, and some of them are concurrently going on for a long time. So think of it as processes that happen together over time. Some of them happen earlier, some happen later. So if we look at hemostasis, so this little diagram on the right is just a visual aid, but the first thing that happens is you get vasoconstriction. So the little blood vessels spasm and they try to stop the blood flow. And you get thromboxanes and prostaglandins from the damaged cells that causes these blood vessels to contract. And as they contract, platelets come along and a platelet plug is formed. And the platelets attach to the exposed collagen from the vessel wall. And so they start making this plug. And as they make this plug, you get degranulation of the platelets, which activates more platelets and increases their stickiness, so that fibrinogen can bond to it. And the fibrinogen then changes to fibrin, which then makes a thrombus or a clot. And clopidogrel, the drug works at this level, so it stops degranulation of the platelets and changes the affinity of those platelets to the fibrinogen. You then also get platelet activating factor, von Willebrand's factor, thromboxane A2, all these chemicals that go and stimulate conversion of that fibrinogen to fibrin, and that's how you get this clot that sits there and stays there. The next phase, inflammation. So that generally lasts over the first 2 to 3 days. So you get the platelets release these pro-inflammatory factors, and that's stimulated by the physical injury or an antigen antibody reaction or infection itself. And it attracts these polymorph nuclear neutrophils, which go to the wound, and monocytes, which will go. They eat up basically all the bugs and the foreign bodies within the tissue, and then T lymphocytes come along to try and give some of an immune response. Lymphocytes secrete more cytokines. So you've got a whole mix of things going on, but basically the body is just sending this inflammatory reaction and all these pro-inflammatory cytokines to start this inflammatory process to help heal the wound. Now, that's good as long as it only lasts as long as it needs to last. The next stage is then proliferation, and the proliferation then happens over it starts about 2 to 4 days and then happens for 2 to 4 weeks. And that's when you get more of the fibroblasts moving into the wound. And that's what's going to start strengthening the wound. So they lay down collagen, which toughens up the wound, and then elastin, which brings back the compliance to the wound, so the elasticity, elasticity to the wound, and you get some of these fibroblasts differentiate into myofibroblasts, and they cause contraction of the wound. So over time, the wound will become smaller and will become tighter, and the scar will become tighter, also in this proliferative phase, you're going to get angiogenesis. So that's new blood vessels forming in the tissue. And that is to supply more oxygen and nutrients to the wound. Because you've got these new little blood vessels going in, you'll see at this stage that the wound becomes red. And that's all those little blood vessels that grow in. And as the wound then matures over time and goes into the remodeling phase, you no longer require all of that oxygen and the nutrients, and so they go away, and that's when the wound starts fading, the scar, sorry. So I have got a little video here. I hope it's going to work. Is it the cardinal sin? Let's just see if it works. Nope. Please work. Oh, that's a pity. Oh, my apologies.
Peter,
yeah.
If you unshare your screen and then reshare your screen, at the bottom left, you probably won't have audio. Go on, try it.
Okay, can you still see my screen?
I can still see it, yeah.
Is it playing now? Huh? Okay, excellent. Can't believe it's actually worked. It's never worked. Okay, so thanks, Dawn. So this chap is a guy from Ireland. He got glassed in the face, but he was doing one of these projects where he was taking a selfie of himself every day. And in the middle of this little project of his, he got bottled in the face, got this cut over his cheek. But it's quite nice because it shows the progression of the wound. So you'll see the different stages. So initially you'll see the swelling and the inflammatory phase, the bruising, then you'll see it going into the into the proliferative phase. You'll see the angiogenesis, so the red scar, and then you'll see it contracting, so it becomes shorter. You'll see it dip down, and then you'll see it going paler in the end as it's remodeled. So that will be up to about 2 years, 18 months to 2 years after the injury. So have a little look. There you go. So when we're thinking about wound healing, what are the factors that affect how we heal? So if we break them down into systemic factors, so those will be congenital, so things that you're born with, so some connective tissue diseases or anomalies like Ehlers-Danlos or progeria will change the way that you heal inherently. There's very little you can do about that. Then you've got acquired, which is obviously the big one for us, and that is wide ranging. It could be from nutrition, so vitamin A, C, E, zinc, copper, selenium, albumin deficiency, what medication you're on, your age, whether you smoke or not, whether you have diabetes or you're immunocompromised, either due to infection or due to immunosuppressive drugs following cancer treatment. There are a number of reasons why you may not heal well. And then if you look at the local factors that are important will be things like, is there any infection? Has the tissue been irradiated? What's the blood supply like to the area? Has there been trauma? And importantly, what is the neural supply? Do they have sensation? Because we know that with people that don't have sensation in limbs, they have delayed healing. And then interestingly, fetal wound healing. So within the first 6 months of being a fetus, you heal completely scarlessly. And they've not really figured out why. But if they go into the womb and perform surgery on babies in the first 6 months, then they don't scar at all. So we're not 100% sure. I think if you find out, you'll have a fantastic life on a yacht somewhere for a long time. In terms of wound assessment, you need to assess the patient and you need to assess the wound. So in terms of the patient, you want to look at their past medical history, their past surgical history, drug history, whether they've got any allergies, social history, do they smoke, where do they work, what do they inhale, and that will give you that picture again of all those acquired elements of wound healing, so things that will help you or will not help you, but will make that you don't heal well. And then lastly, you need to assess the wound. So once you've done your history, you will then go on to your wound examination or your wound assessment. And you'll then consider patient. So there's systemic factors. So what can you see? Are they malnourished? Are they well nourished? Are they mobile? So people who aren't mobile are less likely to heal quickly and more likely to have certain wounds, so like pressure ulcers. Look at the regional area. So look at what the limb looks like. For instance, if it's on the limb, what's the neurovascular status? And then look at the local area itself. So in the local area, are there signs of infection? And what does the wound describe the wound itself? And so you look at the wound itself, break it down. Is it acute or is it chronic? So is it something that's just happened? Is it something that's been there for a long time? And then note, what's the site? Where is it? And how is that important? Is it close to a special area? Is it close to the eye? Or is it on the back of the arm, back of the leg? That changes how we're going to manage that. The size and the depth, as we've explained earlier. The wound surface. So what does it look like? Is there necrotic tissue or eschar, or is it granulating up from the bottom? looking at the wound edges and the surrounding skin. Are the wound edges alive, or are they dead? Are they threatened? Do they look unhealthy? And is there any degloving? So more from traumatic wounds, I quite often talk about degloving, and that is basically when the skin is separated from the underlying tissue. So it undermines at different planes. And so there's like a pocket under the skin that will affect the blood supply to that skin, and so will affect its healing. And then lastly, look at the exudate. So is it pus? Is it just serous fluid? Is it a high output wound? Is it a low output wound? Is it drying up? Describe the characteristics of that exudate. So then moving on to management. So this really depends on what kind of a wound you get. So I know a lot of you guys are pre-hospital, so it's going to be quite simple for you. It's going to be hemostasis, stop that, and that's going to be direct pressure, or apply tourniquet, or Celox if you are. I don't know if you guys have that, but we've certainly seen it here. So Celox is this. I think I've got a picture actually a little bit later about this, but it's a dressing that's filled with chitosan, which is extracted from shrimp cells. So once they've shoved the prawn cocktail into your wound, it makes this gel, which then stops the bleeding. Works really well. So hemostasis. And then you're going to cover it with a non-adherent dressing, and you're going to bring it to the hospital, and we'll take it from there and sort that out. They'll either go to theatre, or they'll get it cleaned up, or and sutured. Other wounds to consider would be chest wounds. So do you need to put on a one-way chest seal, like the Russell chest seals, or burns? You're going to look after those burns slightly differently. So first aid, really important in burns. So you want to put them underwater. So not cold water, just tepid water. You don't want to make them hypothermic for 20 minutes within 3 hours of the injury. Definite proven benefit. Wrap them up in cling film and take them to your nearest burns unit. If you're looking at a chronic wound, this becomes a little bit more challenging, because you need to understand why the wound's there, why it's not healing, and then come up with a management plan. And so you want to create this environment for healing. And so we know how healing works and what needs to be there for healing. So we want to simulate that environment. So we're going to start off by optimizing the systemic factors. If they've got poorly controlled diabetes, you'll optimize that. If they have got a poor blood supply to a leg, you might send them for an intervention to open up the blood vessels. So depending on what it is, you'll try and optimize absolutely everything. Same with medication. There's some medication that they can come off, which is stopping them from healing well. And then you'll move on to optimize the local factors. So if the wound's infected, treat the infection. So wash the wound. Does it need a debridement? Does it need to be the dead stuff taken away to allow it to heal quickly? Do you need to relieve the pressure to allow the pressure sore to heal? Treat and avoid the infection, as I said, and then control the exudate. So there is this concept of moist wound healing. So we know that moist, occlusive or semi-occlusive environments allow the wounds to heal at twice the rate when compared to a dry one. So it's not often we dry wounds out. We want to keep them in that moist environment because they will heal twice as fast. But having said that, that is not the same for all wounds. If people that get necrotic fingertips or a dry gangrene, as you'd know it, those we quite often leave because they don't tend to become infected, and we can manage them that way. But generally, moist wound healing. All right, going into wound management and dressings. So this can be a bit dry. This is very difficult because I think there are probably catalogs and catalogs and catalogs of dressings that people that people can choose from. And within the NHS, that's dictated for you by their procurement routes. So what they've got in the cupboard is probably what you're going to have access to. But broadly, they should fall into one of these categories. And it's useful to think about what you want to achieve for that wound, because you've got all of these dressings. They're adjuncts to help you achieve your goal, to get that wound healed. But you need to understand what they do and how you can best utilize them to get that wound healed. So first of all, I'll quickly run through these because I'm not going to read them off the slide for you. But alginates, so you would have seen these before: Calcistat, Sorbsan. They're alginate based dressing, so they're seaweed extract, very absorbent. We use them to pack in holes. They don't dissolve, so you need to take them out again. Hydrofiber dressings, so very similar, but they form a bit of a gel, and some of them will have silver in them, which is bacteriostatic, so stops the bugs from working. And then you get some debriding agents. Honey is fantastic, great dressing for a number of reasons, and can be used as a debriding agent. So you put it on and it just hydrates the dead tissue and helps it to lift away. There's some more aggressive dressings like Nexobrid, which is that bromelain I've written down there. That's from the stem of pineapple plants, and that you put that on the wound, and it just takes away all the dead tissue. So really useful. You've then got foam dressings like Mepilex or Leave-In. They have a non-adherent site on the one end and a nice spongy bit that soaks up the moisture. So you want to use those for wounds that have minimal exudate. So wounds that aren't putting out a lot of fluid, that can just be sucked up by that sponge. Hydrocolloid dressings, probably my favorite. I absolutely love these, especially on the hands, because they're just like a second skin. So stick them on. They're super flexible. You can use them anywhere, and they just create like another thin little extra skin. The only downside is it can't deal with a wound that's pouring out loads of fluid, so they just become saturated too quickly. And then you've got things like hydrogels, and these you can squirt into wounds. They can be quite active, so they can, in a dry wound, they will wet the wound. In a wet wound, they'll absorb some of the moisture. And so it'll help just create that optimal environment and maybe take away some of that sloughy dead cells, help that to peel away from the wound underneath. Low adherent dressings, so that'll be anything that doesn't stick to the wound. Mepital, Atrauman, Ergotol, Gelinet, you'll have these in the hospitals, and their pure function is just to make sure that the absorptive bit of the dressing, so the gauze or whatever you're going to put on, doesn't stick to the wound and cause pain when you take it off. And then lastly, transparent films, so like opsites, tegaderms, the stuff you stick Venflons down with, things to hold your absorptive dressing down. Lots of utility to them. So this list is by no means exhaustive, but covers most of the dressings that you'll need. And as I said, you'll have access to what you have access to, and you'll have to treat your wounds from what you've got there. So very quickly, just on advanced dressings. So I'll quickly chat about topical negative pressure dressings, or VAC dressings, as some people call them, dermal matrices, and things like alloderm. I'm not going to talk about all the burns wound care dressings, because that's a completely different topic. They have all the dressings in the world, and a dressing for every occasion. But if we talk a little bit about topical negative pressure therapy, so what is it? So it's basically a dressing that goes on top of a wound, and has a little tube that comes out that goes into the dressing on the wound on the one end, and into a pump that sucks on the other side. And what it does is it delivers negative pressure to the wound. And by doing so, it sucks out the extra fluid. It reduces the bacterial load because it just keeps on pulling out anything that's loose. It maintains a sterile wound, if the wound is sterile when it goes on, obviously. And it encourages granulation. So there's certain settings in which you can put it if you want the wound to start granulating or start healing from the inside. Fantastic. We use them the whole time. Two main brands is Vac. So Vac's actually a brand rather than the therapy itself. So that's the top one over there. That's made by a company called KCI. And then at the bottom, there's another one from Smith & Nephew called the Renaissance system. Slightly different. So they've either got this black foam that you can see there that you can stick in the wound, or white foam. And then the Smith & Nephew have got this gauze called Curlix, which is great, where you can pack in and shove a drain and switch the machine on. Very useful. We use it quite often for extremity reconstruction when we need to temporize a wound while we plan our definitive reconstruction. Dermal matrices. Now, dermal matrices are basically a dermal scaffold, and they can be made from various different things. And what they try to do is they're trying to recreate a dermis. When your wound heals, so when you've lost your dermis, so a chunk of it, so say you've burned through it or a bit's cut out, your wound will heal, but it will heal with a nasty scar because the epithelial cells will migrate over the top and meet the other side, but you don't regrow the dermis, and so you lose the pliability and that kind of glide that you have in your normal skin, especially if you're just going to stick a skin graft over the top. And so there are a number of these different matrices, and we use them on the skin, we use them inside the body as meshes or mesh substitutions. And products are like Integra. Integra is bovine collagen, so from cows, so cow collagen and shark glycosaminoglycans in the suspension. You stick it onto the wound once the wound's prepared and healthy. And I've got some pictures coming up, I'll show you. The body then slowly grows into the scaffold. And once it's grown into the scaffold, it absorbs the collagen, because it's just collagen, there's no cells in it, so there's no antigenicity to it, so you don't react to it, and then so it repopulates or reconstructs that dermis, and then you put a skin graft over the top and you get really good results. It's also good for temporizing wounds again, so if you've got a very big burn and you can't harvest enough skin graft to put over the top, stick this on as a temporizing measure so that the donor sites can regrow. Stratus is very similar, but that's from pigs. Surgimend is from fetal bovine collagen. And then quite a new addressing to the market, BTM, biodegradable temporizing matrix. Pardon me. Very similar to the others, but it's not biological. So it's a polyurethane mesh, so it's sponge, and you stick it on the wound, exactly the same situation. Stick it on, leave it there, cells grow into it. Over a long period of time, your body breaks down the polyurethane and replaces it with its own collagen. Very promising dressing. I've had a really good experience with it. The advantage of it over the biologic matrices is that it's more resistant to infection. So the others, if they get infected, they go in the bin, that's it, them done, whereas the BTM's a bit more resistant to it. And then alloderm, so cadaveric skin. So people do donate their skin, and they can process the skin, get rid of the cells, and basically leave you with a scaffold of skin from so the dermal matrices. So if you look on the left there, no, it doesn't show the wound initially, but so if you look on the left of that picture, so where you see that grayish bit of the dressing on the initially, that's where the matrix has gone down. So that see-through layer over the top is a layer of silicone, and this is on Integra. And that's just there to protect it underneath. And then as you can see over time, the blood vessels and the cells go in, the fibroblasts go in, they lay down some new collagen, your body starts growing into it. And then after about 3 weeks or so, you remove that top layer of silicone in theatre, give it a bit of a rub, clean it up nicely, and then put a skin graft over the top as the reconstruction of the epidermis. So then you've reconstructed the dermis and the epidermis, and then that's the final result. So they do heal very well. BTM. So there's an example of what of what it looks like once it's healed. That's obviously had a skin graft over the top right at the end, so bottom right. But you can see that it reduces the depth, so that concavity that wound would have, and the quality of the skin is much better. So in conclusion, how do you manage wounds? So understand wound healing, understand what's important, what are the factors that you can affect, what's this wound going to need to heal, assess the patient and the wound itself. So don't forget that there's a patient on the other end, because quite often modifying their systemic factors, you're going to get a wound healed. Choose the correct dressing, as I said, based on what you needed to do. And when in doubt, ask for help. There are loads of people, tissue viability nurses. We've got phenomenal specialist plastic surgery dressings nurses who know so much about the different dressings and what to use when. They're an absolute godsend. So, and they're always happy to help and give some advice. So that's it.